patient or fast to remember it?
I don't have an acronym that you can use, but I do know that table in Lewis provides you a real good visual on the difference, left-sided and right-sided. Looking at that may help you. It would be wonderful if we had easy to access acronyms for all of those difficult content for us to memorize and to learn. But I think seeing it in a table form like that, where you can compare and contrast the areas of the body that are affected by left-sided versus right-sided, and then getting a good understanding of that. And even better, students taking care of a patient who's experiencing that type of stroke. Okay, that's how you really cement your understanding and learning how to care for that patient and anticipate their needs as well. And if you have your Lewis textbook right now, I can tell you the page that it is on that you can refer to.
Well, actually, I've been able to, because my patient that I have has been experiencing like several TIAs. So okay. I have been able to visualize it and to see it. I can definitely see like the struggling with the words or, not understanding. But that was very helpful about not talking to them like they're a child. You don't have to talk loud to them.
Right, if they're not hard of hearing, it's a matter of understanding.
And they do get upset because they think you're talking to them like a child. So that was very helpful.
Mm-hmm. And the table I was talking about and the contrast left-sided versus right-sided brain damage is located on page 1336, and it is figure 57.4. And I believe some of you are actually doing your clinicals now on a stroke. Is that correct? Yeah. Okay.
I will say one of the ways that I remember part of that too is that for the right side stroke, the right side damage, they are more prone to injury because they think they are all right. So they're not going to be as cautious. They are up and at them and moving around. So they're going to hop out of bed like I didn't have a stroke. The right-sided injury is all right. Only they're not, but they think they are.
Oh, that's really good. Thank you so much. That's what I like that. Okay, thank you.
I have a question, Dr. Hawkins-Johnson. This is Heather.
Thank you, Heather, for promoting me, but I wish you were that easy. And I'm not a doctor yet, but Professor
I apologize. I've heard you correct us a million times. I don't know why I said that.
I don't want to play a hater or take credit. It takes too much work.
We got to speak it into existence. Got to speak it into existence, Mrs. Hawkins-Johnson.
I definitely will. Thank you, students. Thank you so much. All right, Ms. Williams.
Yes, ma'am. In the Lewis study guidebook, in the stroke chapter, question number 9, I just would like some clarification. It asks, a patient is admitted to the hospital with left hemiplegia to determine the size and location and to ascertain whether a stroke is ischemic or hemorrhagic. What will the nurse anticipate that the healthcare provider will request? I chose CT scan with contrast, but the correct answer was MRI, and the rationale was that an MRI could be used to rapidly distinguish between ischemic and hemorrhagic stroke and to determine the size and location of the lesion.
Okay.
I'm confused because I thought that the first thing we would want to do and the most rapid result we could get was from a CT scan.
And you're correct. The CT scan is the gold standard for diagnosing a stroke, period. Okay, so that is what most hospitals have at their disposal to identify the lesion or the area in the brain that is affected by the stroke. Although we know that an MRI can also do that exact same thing. But remember, the difference between the two is that time factor. Okay, a CAT scan can be done quicker with a more rapid interpretation versus, although an MRI is more accurate, but an MRI takes a little bit more time for the findings to be determined and confirmed. And also, in order for a person to get an MRI, they have to meet certain criteria for the MRI, okay? And there's a checklist which must be completed. The patient cannot have any metal or any prostates or any implants made of metal, unfortunately, because as you know, the MRI scanner is a huge, giant magnet, and it could cause problems for the patient. Not only for the patient, but also for the healthcare provider that is caring for the patient. They can't have any metal or things of that nature in their bodies either, even though we know the MRI is more specific and will provide a more precise and definitive diagnosis. But the quickest one is without a doubt that CAT scan, and it's more easily accessible for people. And when a neurologist is looking to determine a stroke, okay, he'll go for the quickest diagnostic tool that's available, and know that the standard of practice for identifying stroke consists of from the time that the person, hits the door to the intervention, no more than 90 minutes, and sometimes it takes much longer to even set up and establish that MRI and make those arrangements for your patient who's experiencing a stroke. Did that answer your question?
So is this an error? Because this says MRI.
Now, for testing purposes, you have to remember that it's asking you what is the most accurate. So if you get that question on a test on an NCLEX, you're going to want to put MRI because it is the gold standard in definitively being able to diagnose the difference. However, in practice, in what we see on the everyday ERs when patients come in, they don't have the MRI always readily available to be able to do an MRI that quickly. So in practice, what we use is the CT scan because it's faster. It gives us at least whether we know that it's hemorrhagic or ischemic, and then we can go forward and treat. That same patient will get eventually an MRI to confirm, but in practice, it's going to be the CT scan. So for testing purposes, if you're looking for the correct answer, it's always going to be MRI because that is the better diagnostic tool. However, when we say CT scan, it's because we practice and we know what happens in an ER when we're there and we're in a time crunch and we want to be able to get this patient treated and diagnosed quickly. So that's what occurs in real life. But as far as the best diagnostic tool that's out there is going to be the MRI. So always think of it, especially for that specific type of question when we know it's the MRI, but we've been telling you that in practice it's the CT scan. It's because we've used both, but the MRI is the better tool. It's just that the CT scan is faster, and that's what we use in regular practice.
And if you look at the protocols for a hospital that's stroke certified or stroke alert certified, which majority of the ones are in this area, CT scan is listed because it's quick and it can diagnose if it's a hemorrhagic or an ischemic. And what Mrs. C said is exactly right. That's going to give you the more definitive MRI. But even if you look at the protocols in the emergency room, it will have a CT scan. But afterwards, once they know what they're looking at and they want to find out more information, the MRI is going to grasp and give them more information about the stroke in itself.
And also remember, students, with that CAT scan, we want to be able to decide whether or not this is going to be a candidate for TPA.
Mm-hmm.
Okay, so if they're bleeding into their skull, you're going to want to not give them that TPA, okay, because it will worsen the bleeding that they're experiencing, and it gives us a little bit more time. Okay, and if you look, and the rationale in the Lewis workbook says that exact same thing that Professor Concepcion explained in regards to it can rapidly distinguish between ischemic and hemorrhagic stroke, and also identifies the size and location of the lesion as well. Good question.
Okay, thank you.
You're welcome. Any other questions, students, in regards to stroke? All right, looking at diabetes and hepatitis. Any questions? And I'll leave the floor open to anyone who has a question. Please share. And my colleagues thank you very much for jumping in.
What specific lab values should we know for diabetes?
What specific lab values do you think would be important for the nurse to know when taking care of a patient that is a diabetic? I'm going to throw it back in your corner. What do you think?
I know glycated hemoglobin, random fasting tests,
A1C, okay.
pre-meal, after meal, but then there's a couple specific ones that I just don't know at the top of my head. I would have to relook into the book to bring it up.
Well, I think you named the most important ones, okay? The A1C, the fasting blood glucose, and also the AccuChecks. Remember, we're helping you to become safe novice practitioners, okay, and not critical care experts. So knowing the most important interventions and responsibilities as a nurse in caring for a patient with diabetes. Of course, you need to know the A1C. That's a given, okay, in order for you to be able to teach your students, teach your patient about lifestyle habits and changing their diet to improve that A1C, knowing what a normal blood glucose level is, hypoglycemia versus hyperglycemia. Those things are important for you as the nurse to know in order to share that with your patient when you're doing your patient education. And when we talk about gestational-induced diabetes in the next couple of weeks, there are some additional tests that apply to the pregnant woman who is a diabetic that we would definitely be interested in monitoring. And the glucose tolerance test would be one of them. Thanks for the question. Okay, who is this?
Jordan.
Jordan, how are you?
Hi, welcome. But okay, so I have a question. It's going towards diabetes with hypoglycemia. So if we had a question stating what would be like the best thing, I was going over my notes today, and I've seen in the hospital that they protocol they give you 15 grams of glucose. But in our notes and like in our PowerPoints, it's like, oh, you can give them jelly beans or you can give them a teaspoon of honey. So specifically, would the best thing be the 15 mgs of glucose, or just depending on how the question's asked, if they're at home or if they're in the hospital, what we would pick for each one? I'm trying to figure out what the best thing would be for that. It just does it depend on the settings the question is asking?
Oh, I think you hit it right on the head there.
Yeah, I think you also, you just answered your own question. So if the setting, if the setting in the question states that you are teaching a patient of what to do if they're hypoglycemic at home, then you're going to give them options that they would be able to obtain while they're at home, whether it be the jelly beans or a specific type of cracker or whatever, 15 grams of carbs, simple carbs that they would be able to get. Now, if your setting of the question states that your patient is in the hospital and your patient is hypoglycemic, then of course, and a protocol states the 15 grams of the glucose, which is the paste or the tube, and we have those available for the patients because they're more specific to giving them 15 grams of simple carbs than a patient who may not like orange juice or may not want to drink orange juice or something to that effect. So the hospital's kind of steered away from using orange juice and now are using those paste because they want to be able to be a little bit more consistent and uniform when it comes to a protocol. And so that's why they did that. But again, your question is going to depend on what your setting is. So if they're home or at the hospital, it's going to be a different answer.
gonna also depend if the person's conscious or not conscious,
Right.
what you're gonna do. You know, even if you're home, they're unconscious, you can't give them the jelly beans, so you would have to call 911. Okay, so again, it goes by what Mrs. C said, depending on the settings. And I think the book does a good job of addressing the 15 grams and what could be some examples. But again, you have to look at, they also have the glucose tabs that people can keep with them, that you can buy at Walgreens, and they're about so big, and they're really sweet, but you got to chew them, but they work quite quickly. So it's always good to have people have that with them when they're in the car or when they go somewhere, because you don't always have your other things with you like you would at home.
Right.
I also want to add on about the paste. The reason why the physicians went to that is because we have a lot of renal failure patients and they can't take the potassium that's in those juices. So that's why they went to the paste.
Right. Thank you, Ms. Castillo, that's true.
Thank you, guys.
All right, diabetes, any questions about hepatitis, students?
I got more questions.
Is that Jordan?
Yes, I have more
Jordan,
questions.
Jordan, we're gonna start charging you, dear. Go ahead.
Listen, as long as it's not a lot, we're good. I'm on a nursing student salary, okay?
Oh, no.
Okay, so when it comes to hepatitis A is what you would see a lot from restaurants, right? People aren't washing their hands, so you're basically eating somebody else's, I can't cuss, but other people's feces, correct? And then, question about that though, there's that, but then there's H, isn't that the same thing with kind of like E? But E's from a different country? So how do we like separate them? My question is, how do we separate A from E, unless I'm really off?
It's
Good one.
A is, yes, it's what you would see here in the United States, from restaurants with people not washing their hands and the oral fecal route. So yes, E is more so, it's the same route, but it's,
That's what you see more in third world countries.
yeah, so it's more so like the contaminants are more from third world countries.
Right.
So
So
they're
that's
not common to the United States.
Okay, so the basic thing is just to remember, like, one's just out of the country, does the
Right.
same thing, and one's in the States.
Right.
Yeah. What's
Okay.
like fecal oral versus what's like bloodborne.
Right.
And HPV is having, like, HPV. I mean, the B one is from sex, correct? Let me just I'll go look at my notes.
Also
Sorry,
bloodborne
guys.
too.
Thank you.
We're still gonna charge you, Jordan, extra. Any other questions about hepatitis, diabetes?
I just got a quick one. I'm coming in late. Sorry about that. But with the insulin, the most important thing we need to know for our exam is the peak, correct? And you use the peak for like plates, like you want to feed the patient some sort of simple carb with the food. Okay, I just wanted clarification on that. Thank you.
You want to make sure that they have some, okay, so that their blood sugar does not drop. Yeah, well, you're on the right track, you're fine.
I think what you may be coming from too is that one video that we showed talked about, because he stressed the word plate, like peak and plate. And for that, we're not necessarily talking the simple carb. We're talking, if you give that insulin, they need their plate, they need their meal. So don't confuse that when we're talking about glycemia, then we're talking about that 15, 15, and 15. 15 is a simple complex. Check the AccuCheck, then another 15 minutes. If it's still below 70, another 15 of a simple complex. But when you're talking just the peak times of insulin, don't put the simple complex into that. It's plate, their meal.
Give them an actual meal during the peak time.
I think that's what that video was trying to say, peak and plate. Peak,
Okay.
a meal when he was given that plate.
Thank you.
And remember that your long actings do not have a peak time, and they can't be mixed with other insulins. So you need to know that. Like your Levemir, your Detromir, your Lantus. So make sure that you do know that those do not have peak times.
And then remember that only regular insulin can be given IV. That's important to understand too.
Mm-hmm. Very important.
In addition to what Mrs. Castillo said.
You just triggered another thought for me, Ms. Dr. McCusker, is we're talking about regular. So what else happens with regular? Like we talked about when we did our simulation, we drew up 2 different kinds of insulin. So have in mind too, that was the whole purpose of that part of the simulation of how do you go up about drawing up 2 different types of insulin, the clear and cloudy, the regular and the others. What steps do you take? And that was the point of that simulation exercise.
The other thing just to share about that is at the Baycare hospitals, they're not mixing. I mean, even though the book show it and other facilities do, they're not mixing the regular and the NPH. They have to do them separately. It's been for the last year and a half, 2 years, I think, 2 years. So in practice, if you're giving insulin and you're thinking, I can do this like they do at the school, you may not be able to do that in the facility, especially if it's a Baycare. I know at HCA right now, they still do the NPH and the regular. I don't know about the VA, but just know that that may come up.
All right, students, we'll move on. Any questions in regards to cancer? General cancer, and we also discuss colorectal cancer and breast cancer.
The one thing I do want to share about cancer, please, please, please do not memorize the chemotherapy agents. Okay, those are in protocols that doctors have to look up. Just understand, and that's why I'm saying this. I don't want you to waste your time doing that. I want you to know about what are those side effects that could occur with cancer, with getting chemotherapy and radiation. And what do you as a nurse need to know? Just like your lab values, what do you need to know, and how would you help treat that patient with your nursing knowledge, but also the things that the physician may order for it. I don't want you to get hung up on those meds. Okay, don't go looking at those meds and say, I got to memorize all those. Okay, so worry about what you would do as a nurse and what would you follow from orders that might, and lab values that might indicate you have to do some teaching. So I just want to clarify that.
Yeah, like neutropenia, thrombocytopenia, the alopecia, the stomatitis, all those potential side effects that can occur and what you can do.
And if you remember,
tables in the book.
I'm sorry, go on.
Oh, no.
If you remember in your book, and I don't have my book right in front of me, there's a couple pages, or maybe like 2 pages front and back, that actually tells you, like, if you have neutropenia, what do you teach? What happens? It very clearly talks about the nursing management. And I think that's a good thing to really look at. And I think it will get you into thinking like a nurse. Okay, that's what we want you to think like.
How important is the grading scale for tumors and cancer, would you say?
No, I remember we talked about the T&M scale. Practice that. That we don't worry about the grading scale. Remember when, I don't know, I'm sorry, in my class I said that when I was lecturing, but the T&M scale, the tumor, the nodes, and the metastasis, there's some examples. Practice what that would mean, okay? But otherwise, the scale, don't worry about the scale and the grading. Don't get yourself crazy on that.
Thank you.
You're welcome.
The table Dr. McCusker was referring to the nursing and management of the patient receiving chemotherapy or radiation therapy. That is in your cancer chapter, chapter 15. It's starts on page 249, 250, and 251. And again, it looks at nursing management of each one of the problems that are caused by the chemotherapy that the patient is receiving and or the radiation therapy. So you have to be able to treat your patient's signs and symptoms and also be able to teach them about what they can do to soften the effects of that chemotherapy. You know, how to tolerate, how to manage it in their day-to-day lives. They undergo chemotherapy for weeks and weeks at a time, and often are reluctant to start chemotherapy because they hear about the bad side effects. You know, how it makes them lose their appetite, they'll lose weight, their hair will drop out, you know, alopecia will occur. You know, so just knowing what can happen and preparing your patient ahead of time is one of the best things that you can do as a nurse caring for a patient who is undergoing chemo radiation therapy. Remember, it affects each patient differently, okay? And also remember that the chemotherapy and radiation therapy is individualized.
I'm sorry, someone else had this is Tatiana speaking.
Tatiana.
Hi.
Hi.
Another student had a similar question that I wasn't going to ask, but since no one answered it, I'm going to just ask. It was about hepatitis, exactly knowing. I'm just trying to understand how much of that I need to know. Like, as far as I know, preventative, like patient education on how to prevent it, but is it in the route of how someone can, you know, get these type of diseases? But I'm trying to figure out how deep do I need to dive in there on all of these different hepatitis.
In other words, keep it simple.
Yeah, keep it simple. You just need to know how it's transmitted.
Okay.
What are some, maybe the signs and symptoms of it and how we treat it.
Okay.
Mm-hmm.
Thank you.
And, you know, prevention, especially hepatitis A. You know, it's similar to the flu almost. It's like they think they have the flu, the symptoms of flu-like. And it usually goes away on its own.
Thanks for that, Professor. Any other questions, students, on cancer? Breast cancer, not one on breast cancer? Nothing?
Any big points to share?
This is your out-of-class report. What would you like to know? Not other than what is on the test, okay?
Remember that the side effects for radiation and chemo are yes, there's different drugs, but they're going to be for those kinds of cancer of the breast and colon. Just really, and I'm going to share this with you, understand, like, what is cancer of the colon? And what are the things that they might do, and the standard tests that they may need for cancer of the colon? What's the gold standard? How do they treat it? Those kinds of things. Same thing with breast cancer. What's important about that? Where is it usually found? How do they treat it? Not the drugs for it, but, you know, certain specific things that they might do. You know, think about the safetiness of when you're giving chemotherapy, or if you're having, remember, I'm sure Dr. Clem spoke about it, brachytherapy. What's important about brachytherapy? So when you're reading, think about those things. How do you protect yourself? How do you protect your client? So that's really important stuff, because we got to protect ourselves when we're giving chemo. We got to protect our client, their visitors, if they have any, and future nurses or aides and stuff. What do we need to know? So it's, you know the testing, you know, what kinds of tests and things, plus those kinds of things. That's sort of a little hint, okay?
So you seem to be really emphasizing nursing interventions as opposed to pathophysiology, how it progresses.
Well, if you think of pathophysiology for cancer, it's just what's happening to the cells. That's the big thing. So you know what happens to the cell. Something disrupts the DNA, then it gets mutated. Then after it gets mutated, it starts dividing all crazy. Doesn't divide like a normal cell. That's the biggest thing about cancer, is what happens to the cell. So you need to think about, for studying breast and colon, what is specific about breast cancer? You know, what is specific about that? What are those things that, you know, might affect those cells? How do they treat it? You know, those kinds of things. So it's I know it sounds simplistic, but, you know, don't sit there and memorize all that stuff in the beginning of that chapter, and general chapter about cell division. You should know that already. Go to what actually causes cancer, if you're gonna look at it that way. Okay? A nursing aspect is the main thing when you're talking about cancer.
And students, that is our focus. We want to help you to train your thinking so that you are not only a safe practitioner, but you're able to identify potential problems that can occur, when a patient is experiencing any disease process, okay, not just what we're studying right now. Okay, we're trying to help you to develop your critical thinking process. And this is one way of doing it, helping you to think like a nurse, to act like a nurse, okay? And eventually you will be the nurse at the bedside responsible for caring for patients. And it's important that you know what the basic expectations are as far as nursing interventions are concerned. Any other questions, students? Professors, any other input? How many of you students have had an opportunity to complete the quiz on exam 4 content that I placed in the course over the spring break? Just by a show of hands physically, I'll just roll through the screen. Good, did you find it helpful? Okay, the rationales are there for you.
Where do we find that, Professor?
Say it again.
Where do we find that?
I placed an announcement in the course, and it has the website that you go to and the code number.
Okay.
For Quizlet.
It's expired now.
I think I had it open up until this afternoon. I'll go back in and open it up for you for those of you who are gluttons for punishment, who want to do it again and again for practice.
Thank you.
After this out-of-class support, I want to get feedback from you first to find out if you felt it was helpful. We had a variety of questions that I added, including stroke. Professor McCusker added several of the majority of the questions on cancer. So I think that there was a nice variety there for you. Our plan is that we will offer that to you for exam 5 and exam 6 as well. But you guys know that the key to your success in taking tests is mastering your test-taking skills. And the more you do it, the better you get at it. You're helping to form your minds to think like a nurse and to analyze like a nurse and to critically think. And it all comes together in the end. But yes, practice makes perfect, as we know. And you also know that our NCLEX is going to be changing. We talk about this all the time. NCLEX is going to be changing soon in a couple of years. So we want to make sure that we're helping you to become ready for that as well. So critical thinking is something that you'll get tired of hearing about, but it is an important skill for you to have as a novice nurse at the bedside. It's an important skill as an experienced nurse at the bedside. Okay, faculty, any
Hawkins? Oh, I'm sorry.
other input?
I just want to say, if you do the quizzy, even if you get the answer right, I think it's very helpful. Don't blow off the feedback, because the feedback will help you understand why some of those other ones that maybe you were guessing between 2 of them would be wrong. So I would suggest that if you can definitely look at the feedback for each one of them, because it shows this is why the answer is correct, this is why the answer is wrong, and it's written very well. So I think it may help for study purposes.
I apologize for asking this question so late, but real quick question, because I've read it and I've seen a couple of different answers. What is the A1C minimum? Is it less? Is it 6.5? Is it 7? I've seen 4.5 some places, and I know we're supposed to go by the book, but I was looking in the book, and page 1633, I think, and I didn't see it, but maybe I'm not looking in the right place.
Are you asking for the range of the A1C, or pre-diabetic or diabetic? What are you asking?
I apologize for pre-diabetic, and then the range, please.
Or, you know, so 5.7 to what? Do you remember?
I thought it was 6.4.
6.4, and then 6.5 is diabetes.
Okay. Now I understand. Okay. All right. Thank you so much.
You know, with your interventions as a nurse, you don't want them to be a diabetic, so while they're in their pre-diabetic stage, you want them, the interventions you want to use is positive. Eating habits, exercising. Got it.
What's really important to know about that A1C is it's a report card of what that patient's been doing over the last 90 days or 120 days. Because, you know, some of our diabetics are very non-compliant and they know they're going to the doctor's office. So they start like 2 weeks ahead of time, start taking their insulin and stuff. But what they don't know is that A1C is going to tell us what they did 120 days before that. So it's a report card to tell us if they've been compliant or not, or if the regimen is working for them. They may be compliant, but the regimen is not strict enough for them.
So is the 90 or is it 120 days?
It's 120 days. It's about 120 days because that's where that hemoglobin sits on there. It sits on that hemoglobin for about 120 days. But the range is about 90 to 120 days.
It's about the lifespan of the red blood cells.
Yeah.
It's the lifespan. So it'll range somewhere in there. It's the lifespan of the red blood cells and how much damage is occurring to all this blood sugar.
Yeah.
So I like to think about it.
Report card.
That Mrs. Costello said it very nicely. I think that the A1C is a stool pigeon. It tells on you. So when you go to the doctor's office, you say, I've been so good. I've been following my diet, and then he has the results and he's looking at you. Well, tell me more. Or it could be that you're out of whack and they have to readjust things, but it tells you a story. The other thing is they're starting to use it in their physicals to screen. They used to only use it for diabetics. Now they're doing it to catch to see if you're a pre-diabetic. So it's becoming more of a screening tool also.
Well, Dr. McCusker, I love your stool pigeon analogy.
That's right. It's a snitcher cat or a stool pigeon. It tells on you.
Great
We
input.
were told about that fasting because there was a question that we had, and I know like it was like what was I don't remember the exact question, but it was about fasting. I know that they say like fast before you go get your lab or your blood work, but I know I got it wrong because it was like saying that they don't need to know what you had in the past or the day before. But I don't understand what's the difference between the day before versus that morning, because you still want them to fast before they. I think it was something about them fasting that morning versus fasting the night before. I don't know, any clarification because I'm lost.
I remember the question, and it just asked if a diabetic was going for a test in the morning, when would they start fasting? And the answer is 8 hours like everyone else. Is that what question you meant?
Okay, thank you.
Mm-hmm.
Yes, that's the
That doesn't change just because they're diabetic. Now, their doctor can choose to change that if they need to, from my understanding, but I think that's the question you're referring to.
But in real life, if you go get an A1C done and I ate like 4 hours earlier, is that going to give me the correct results then?
But you have to fast 8 hours.
So you have to. You know what?
You don't have to fast for an A1C.
See, that's what I'm getting. I'm getting you have to, you don't have to. And then when I try to think critically, I'm just talking to myself in circles at night.
About two different tests. You're talking about two different tests. You're talking about a fasting blood glucose, and you're talking about an A1C, that's totally different. An A1C is what we need to know what they've been doing for the last 120 days. A fasting is something that we want to see if they're within that range. To diagnose if they're pre-diabetic or not.
Mm-hmm.
Those are two different exams.
Okay, so just looking for those key words to help me know the difference between what they're asking, because that's what's helped with the test that you posted during spring break. I was able to see okay, well, I need to slow down and see what's asked, because then I will determine how I properly answer the question, because I might know the answer, but I'm not noticing those little key cues.
The hemoglobin A1C is longer term. It's more like that 90 to 120 days. It's longer term versus the fasting. It's longer term. It's like, how are you looking over a period of time? Because you may have times, for some people, they'll be hypoglycemic and then there'll be hyperglycemic, and back and forth, back and forth. So this is long term. Because they may start being real, like I said before, they may be really good right before they go into the physician's office to say, yeah, my blood sugar's great. And maybe they even give themselves a little too much and they look hypoglycemic, but then you check the hemoglobin A1C and it's 10, and you know that they've been in very poor control. So it's longer term.
I'll give you an example, Tatiana. My husband, who refuses to go on insulin, has been, treating it with pills and losing weight, which but anyways, right before he goes to the doctor, he starts, walking more and all this stuff, and they'll do a fasting glucose, and he's 110, right? But then they do his A1C, and it comes back, and it's 9.4. And guess what? Mr. Castillo's, been lying. So that's kind of a part of what's been going on prior to that morning. That morning was 110 and he looked really good, but when they took his A1C, it was different. Told a different story.
The stool pigeon.
Yeah.
The stool pigeon.
Exactly.
Castillo, can I ask a question?
Charmaine?
So for the A1C, you don't have to be fasting, but they do recommend us not eating after midnight. How does the basal body affect, or does the basal affect the A1C at all? No. Okay.
Because that's not what you're measuring. You're measuring what's on that hemoglobin.
Right. Okay.
Mm-hmm.
And think about it. If you're going to the doctor or you're getting your lab work done and you're getting a bunch of stuff done, including A1C, they may tell you to fast, but it's like Mrs. Costello said, it's not going to make a difference for the A1C. They're not going to say, fast for this and not for that. You're fasting for whatever else they might have you, for a fasting glucose, and they're at the same time doing the A1C. But it will not affect the results, just like Mrs. Costello said. So that could sometimes be confusing. But just remember what Mrs. Costello said about the 90 to 120 days. Okay.
All right, students, we're going to call it a day. I will open up the exam for Quizlet for you, which is the practice set of questions for you. Exam for it is indeed tomorrow. And we will be beginning STI and preconception health as well. I was told that some of your students were having problems getting your access to the Ritchie textbook. Is that correct? Some of you have it, some of you don't. 4th edition versus the 5th edition, doesn't matter which edition you get, just as long as you have one or the other. Okay, the content isn't that much different from edition to edition. And as soon as I receive from the publisher the correct link for you, I will place that in the course as well. And concentrate overnight on studying and practicing questions, okay, in the application component of answering those questions. Okay? All right. That's it for now. Thank you for attending.
Thank you for having it.
No problem.
Thank you.
Thank you, guys. And yes, you look lovely in your uniforms. You always do. Big blue. I know it's boring, but it's unity.
Thank you, Mrs. Hawkins Johnson.
You're welcome, dear. Take care. Good
You
luck
too.
to you tomorrow.
Thank you.
Good luck. We'll be online waiting for you. If you have any questions while you're getting ready to test, we'll be available to you. Maria, are you staying behind for me?
Me?
Yes.
No, I'm just looking. Okay, it's like, are we supposed to leave?